One of my friends who was my senior in residency is a palliative care attending, and she said that November is palliative care month. So here are some of the reasons why they are my favorite kind of doctor. Here are some things that are true and not true about palliative care as I understand it, and I'm curious to think what you guys have to say about palliative care docs as well. One of the first things is palliative care is not the same as hospice care. Hospice assumes that there is a certain life expectancy, or within a certain amount of time, someone is going to live the rest of their life. But one of the ways I've heard palliative care described is what is important to that patient and how can we preserve that as much as possible. Is it prioritizing pain control or nausea control? How am I able to eat food instead of supplemental nutrition? When I go to the hospital, do I want antibiotics? Do I want fluids? Do I want supplemental oxygen? Do I only want to be comfortable? These are things that are malleable over time, and they are within the patient and their loved one's discretion in conjunction with the palliative care doctor. It is their field to preserve as much integrity and the goals of the care that the patient wants longitudinally. But here's a common misconception. Palliative care doctors are not your tough conversation provider. That is still your job, right? If you are a surgeon and you have someone who's a poor surgical candidate and you don't want to have that conversation because it makes people sad and people are uncomfortable and people will be emotional, that's not the palliative care person's job to have tough conversations for you. For the same reason why it's not psychiatry's job to judge capacity on people. You're a doctor, you're a specialist of some variety. You are able to have tough conversations. Now, it is inherently a pretty multidisciplinary field. They work with social work, case management. Do they need home hospice if it's a hospice patient? Do they need home care nursing? Do they need someone to administer IV medications at home or oral narcotics through a G-tube so they're comfortable if they have metastatic cancer or something like that? Sometimes they work in conjunction with acute pain services, which sometimes could be through palliative, could be through anesthesia. But you don't need to be dying to discuss anything with palliative care. If you have late-stage COPD, you're on 6 liters of oxygen at home, you have severe congestive heart failure, you're on dialysis, you have quality of life that you're not happy with, palliative care can help walk you through that, even if you have more than 6 months to live. I don't think I have ever consulted a palliative care service and regretted it, ever. I don't think it's ever been a time where a patient was worse off talking with palliative care. There have been times where I'll discuss palliative care as a concept, as how I describe it to you, to a patient, and they're not ready for it, and that's also valid. But even if you have metastatic cancer, you have an aggressive chemo regimen, they can still be helpful and walk with you to make sure that the goals you have in care are acknowledged and prioritized. They're great people.